I'm going to briefly cover finding therapies to improve longer-term outcomes from COVID-19. The illness itself has sort of three distinct phases, and just to be clear about the bit I'm talking about, there's a pre-acute phase, the acute illness itself, and then a post-acute phase, which can be for some people very short, but for many people actually it's very prolonged. And the different bits of the immune system and the host pathogen interaction are probably pay more or less importance at different stages. Initially, antiviral responses are probably the key thing that's happening, but later on in the disease course, the host immune response also becomes particularly important. There are three things that can happen to you if you have an acute COVID infection. Essentially, you can fully recover, you can get persistently ill, and you cannot recover or become ill because you've died. Now, it's slightly more complicated than that, because actually we know that the acute illness can happen in the community, it can happen to people that are hospitalized, and it can happen to people that are actually so sick they need to be in an intensive care unit. And for all of those people, actually they can go on to have what we know as long COVID, or they can get better. And for the ICU people, they can also develop what we've known for many years to be persistent critical illness. That's probably a consequence of some of the things that we do to you in intensive care alongside having been sick. You know, being in the community and being hospitalized both have a consequence that you may have persistent symptoms and not fully recover from your illness. For the hospitalized patients from wave one, we've got some really clear data as to what happens. So about 30% of them were readmitted to hospital, 12.5% of them died, and 58% of them survived and weren't readmitted, and all of these were in a median of about 140 days after their discharge from hospital. We had a look at that in terms of the FOST-COVID, which is a national observational study in the UK, which has looked at people who survived hospital and who've come back to some research clinic assessments at a median of about 5 months after their initial hospital discharge. And what they found is that 29% of people said they felt fully recovered, 20% had a new disability, and 19% of them had had a health-related change in occupation. Now, this is data just on a hospitalised cohort. The data will be slightly different for a community cohort, and I'm not sure that we've got as good a data as we should have at this stage in the pandemic. But there is a significant burden of health-related changes in occupation and ongoing disability in people who have community infection who were never hospitalised too. The kind of pathologies that are being identified alongside the symptoms that Annie talked about, actually there are well and increasingly recognised organ dysfunctions and diseases that are clearly documented. People are reporting neurological diseases and issues with motor, sensory, autonomic nervous systems, as well as cognitive and psychiatric impairments. Cardiovascular illnesses, so arterial and venous thromboses, have been well reported, but there's clearly an increased risk of bleeding, particularly early on, that's been reported in multiple studies now. Respiratory, we're seeing persistent respiratory inflammation, as well as the cough, and in a proportion of patients, fibrosis. There's also increased incidence of new diagnoses of things like diabetes. And one of the things that's common for some other severe infections, but definitely being seen in increasing frequency, is an increased risk of subsequent infections, both with SARS-CoV-2 and other sources of infection. So how do we find therapies? Well, I went looking at clinicaltrials.gov to see what trials are there that are registered, that are in clinicaltrials.gov, that have completed and reported results. This is the sum total of trials that have documented in clinicaltrials.gov this morning as being completed that were drug studies, so looking for therapies to improve long COVID. And you will see that actually results are available from one study of sodium pyruvate nasal spray, which is a very short-term phase 2 study of 22 participants. One study was withdrawn before enrolling anyone, so a fluoxamine. And the others were a mixture of drugs and dietary supplements. And in the main, all of them, apart from the probiotic study, were incredibly small studies. And results are not available for almost any of them, which is somewhat disappointing at this point. Currently, these are the open studies that I could find listed in clinicaltrials.gov of interventions. So again, quite a few of them are of dietary supplements alongside those of drugs. So there's vitamin D, there's lithium, there's some other sort of interventions that are for inhaled therapies that might help the upper airways. There's a variety of drugs aimed at either immunomodulation or at some of the vascular inflammation, such as atorvastatin, and some of them around antivirals, because there's some Paxlovid longer term studies coming up too. But I think, again, the studies are predominantly small, often single centre, not of an appropriate size that we will ever get out of them evidence of efficacy. So I wanted to highlight two particular studies. One I've got a conflict of interest in because I, along with Mark Toshner and the chief investigator, and this is a study that's UK-wide to try and find therapies to stop people who were hospitalised initially with their COVID coming back into hospital or dying in the 1 year after their index admission. So we're recruiting hospitalised adults who approach the end of their admission to hospital. We're using drug therapies that were selected by an independent expert panel in comparison with usual care, and the outcome is hospital-free survival at 12 months. We're also collecting a range of secondary endpoints, including patient-reported outcomes, so we can understand how people's recovery journey is going and their health-reported quality of life. So we're recruiting people, as I say, at the time they're ready to leave hospital, and we've been randomising them to usual care, to apixaban for 2 weeks. Now, just to be clear, this is 2 weeks from the discharge of hospital. So actually, the majority of people have been in hospital or have had 12 days from their point of COVID positivity to leaving hospital. So actually, they're getting anticoagulated over most of the first 4 weeks, which is the highest incidence of venous and arterial thromboses in hospitalised people with COVID, or atorvastatin, and then we've got room for potential new therapies. For each arm, when there's 181 primary events, there's an interim analysis, and the apixaban arm was stopped at the interim analysis, and it was stopped because actually when we had 402 people who got apixaban and 399 who got usual care, there was no change in the incidence or the rate of death and rehospitalization over 12 months. But I think the stark finding from this is that despite everything we have done to improve outcomes for acute disease in the course of the pandemic, the chances of dying and being rehospitalized in your 12 months after a COVID admission remain 30%. In terms of did we prevent any thromboembolic events? Well, yes, there were thromboembolic events that occurred in not in the apixaban arm, that were in the control arm. However, we had 3 cases which exactly balanced the thromboembolic events of clinically significant bleeding during the 2-week therapy with apixaban. So for the PEs and thromboembolisms we may have prevented, we also caused some bleeds. So it probably, the IDSMC and the TSC felt that actually there was no benefit in this therapy. Now, this is to prevent getting disease rather than treatment. So this is not for people with long COVID. This is for people who have been sick with acute COVID to try and stop them getting longer term consequences. There is a big national study in the UK called Stimulate ICP, which is looking at adults with persistent signs and symptoms that they've got to have had for 4 weeks in their post-COVID period, and who are presenting at their first referral visit to a long COVID clinic. They are looking at giving these people 3 months of either loratadine or formotidine, the antihistamines, colchicine, rivaroxaban, the anticoagulant, or usual care. And they're using a primary outcome of fatigue measured using the fatigue scale at baseline 12 weeks and 24 weeks. And so far, when I looked this morning on the NIHR dashboard, they've randomized 373 people from 6 sites, and they're aiming to recruit 4,520, give or take, participants into the drug part of this study, which means it will be of a scale that actually we will get answers as to whether these therapies are efficacious or not in COVID. So I guess in summary, The long-term consequences of SARS-CoV-2 infection are now very well recognised and documented. There's a significant burden of disease and adverse health impacts for many people who've experienced COVID, and we are not doing enough if that's the entirety of the drug studies that we have. There is an awful lot more that we need to be doing.